my name is Dr. Fatima Rodriguez, and I'm a cardiologist and lead the section of preventive cardiology at Stanford University. In our clinic, we take care of many patients with familial hypercholesterolemia, or FH. And FH is an inherited disorder that results in high levels of low-density lipoprotein blood cholesterol. So now let's get to your questions. What a great question. So overall, reducing your LDL cholesterol reduces your risk of heart disease. There's no question about that. However, it's a little bit more complicated than that because really it's your cholesterol over time. So one value alone is not sufficient to give you a specific answer. But in general, the amount of risk reduction is dependent on several things, including your risk, your age. And for each 1% reduction in your LDL cholesterol, there's about a 1% reduction in the risk of heart disease. So in the example you just gave me, reducing your cholesterol from 200 to 100 may reduce your risk in half. The studies have shown that there's about a 31% reduction for each 30 milligram per deciliters reduction in your LDL cholesterol. So maybe a little more technical than you asked, but essentially the lower the better. But the most important thing is that this reduction is consistent over time. Thank you for this question. This is something that does not come up infrequently in our clinical practice. So fortunately, there are now many non-statin therapies that are known to very effectively lower LDL cholesterol and reduce adverse cardiovascular outcomes. So these include medications like ezetimibe, PCSK9 inhibitors. It can either be an injection that you give yourself as a patient or that you can get in clinic as a form called inclisiran. There are other oral medications and injected medications, and in extreme forms, there's apheresis that's available. Great question. It comes up a lot because we know that our patients with FH, fortunately, are being diagnosed younger and younger. And the short answer is yes. I consider a statin a lifelong medication that is very effective, and we have data showing that the sooner you start it, the greater the benefit. Great question. These are very sophisticated questions from our audience. So FH is a genetic disorder. So it's really important to tell our patients. But genetics is not really destiny, and diet can certainly contribute. Your specific gene mutation may just determine the severity of your high cholesterol. So again, diet can help and can contribute, but these are genetic problems for monogenic FH as opposed to polygenic FH. Great question that I get asked by all my patients, not that just those with FH in our cardiology practice. So in general, I don't recommend any one diet in general for all patients, but I would suggest avoiding diets that are very high in saturated fats or very extreme diets that are hard to sustain. The diet that I'm not a fan of because it does raise your LDL cholesterol is the keto diet, or a very high fat, low carb diet. And I tend to recommend diets like the Mediterranean diet that are rich in vegetable, whole grains, and lean vegetables. Absolutely. So patients with homozygous FH or HoFH have much more severe disease. So it's very helpful to know. It's fortunately more rare. It may not respond well to the standard cholesterol lowering medications that specifically target the LDL receptor in the liver. So you may need different therapies and more specialty care. And in many cases, you may need apheresis. So absolutely, it changes our treatment plan. This is a great and sophisticated question. So when we test for FH, so a patient that comes in with high cholesterol and other criteria, we sometimes get a result that they don't have, quote unquote, a causative mutation for FH. And these are the genes that we have identified that we know can cause very high cholesterol. Polygenic hypercholesterolemia is much more common. And this means that there's not just one gene, like monogenic FH, but many genes that together can contribute to having a predisposition for high cholesterol. And these can be in things like a polygenic risk score. Now, the data has not been compelling to show that testing for this polygenic risk score can change outcomes, but there are certainly a lot of tests out there and available for those interested. The most important thing to know when you have polygenic hypercholesterolemia, again, is that genetics is not destiny. And a lot of times changing a lifestyle can really improve your cholesterol level if you don't have a monogenic FH cause. Sometimes we may just not know the mutation yet, because we haven't identified all the causative mutations for FH. So we still treat you as if you had FH and lower your cholesterol with medications. Great and very sophisticated question. As a cardiologist, I'll say that even some of my colleagues don't quite understand this. So in general, plaque that is calcified is more stable than that is soft. And especially in young people, soft plaque is particularly vulnerable to flicking off. And when that plaque flicks off, it can cause a heart attack. So again, that's our best hypothesis of these unstable plaques causing heart attacks. The best way to stabilize plaque are statins. So again, we've done studies that have shown that plaque that is soft can become calcified after starting statins. So absolutely lowering your LDL cholesterol as low as possible with medications like statins and others have really shown a reversal in plaque and a stabilization of soft plaque into hard plaque. Again, another great question, and I would say our evidence is changing a little bit on this. So in general, for my women patients that I treat with FH who are trying to conceive, we continue the statin until they are confirmed pregnant. Now, understandably, sometimes the patient may want to stop the statin because of some concerns around the safety, particularly in the first trimester. That said, we do treat the LDL with other medications that are safe in pregnancy, and these include bile acid sequestrants, which again are not absorbed, but they help you not absorb the cholesterol so that your LDL doesn't get very, very high. High LDL in itself, without statin therapy, has, to my knowledge, not been linked with infertility or other issues. But that's also a great question that I think our audience asked. And again, the alternative treatment here for women with FH during pregnancy, during breastfeeding, that is extremely safe are bile acid sequestrants. Great question. So lipoprotein A is now becoming an increasingly recognized marker of increased risk of heart disease. It is separate from FH, which is due to typically a monogenic mutation in the way your body makes LDL cholesterol. Now, we find that many of our patients with FH also have a high lipoprotein A level. So they're separate and independent, but they sometimes occur together and the risk is higher. So FH is a clinical diagnosis. And again, that means really that even if you don't have a genetic test, but you meet certain clinical criteria, and even if your quote unquote genetic test is negative, you still are treated like FH. And FH means that, again, you have very high blood cholesterol, higher than would be expected. And this tends to run in families. So even without a genetic test, you can carry a diagnosis of FH. But we do find that patients with FH have higher Lp(a). Now, for right now, we don't have a treatment for lipoprotein A, and the best treatment for those that have high lipoprotein A is to lower your LDL cholesterol. And that's particularly important for those with FH. Thank you so much for these really wonderful and sophisticated questions. I really want to encourage you to learn more at familyheart.org. And if you need help in your healthcare journey, which is particularly challenging with the diagnosis of FH, please contact Family Heart Foundation Care Navigator. We're here to help.